Hello, I'm Dr. Daniel Kuritzkes from the Division of Infectious Diseases at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. You've heard excellent talks by Professor Anne-Geneviève Marcelin and my colleague, Dr. Sanjat Kanjilal, on the basis of molecular testing for detecting SARS-CoV-2 and antibody testing for diagnosing COVID-19. In my talk, I'd like to place both of those presentations into a more clinical and public health context in terms of how can we actually apply these assays in the clinical setting. I have no relevant disclosures related to this talk. So there are a number of ways in which the virologic assays for detecting SARS-CoV-2 itself might be used clinically. These include diagnosing COVID-19, demonstrating clearance of COVID-19 in people recovering from the disease, screening patients on admission to the hospital, screening in specific patients who may be undergoing procedures that are likely to generate aerosols in order to protect the healthcare workers performing those procedures, and potentially in certain settings, screening employees. So let me discuss each of these in sequence. The diagnosis of COVID-19 has really depended up until now on the use of these molecular tests, particularly the use of nasopharyngeal or oropharyngeal swabs. And as discussed, one can use other sample types such as saliva and, of course, tracheal aspirates or sputum when available. These tests have high sensitivity and specificity, although certain rapid tests may be less sensitive than the classic PCR-based assays in certain settings. Nasopharyngeal swabs, however, can become negative later in disease, particularly in patients with prolonged infection where pneumonia comes to predominate. And in those circumstances, if a diagnosis has not yet been established when the patient presents with pneumonia and potentially respiratory failure, using sputum or tracheal aspirates if the patient requires intubation and mechanical ventilation can be a very valuable adjunct to nasopharyngeal or oropharyngeal testing. There's much less value in performing quantitative testing on the clinical side. That really remains a research tool. There are no validated quantitative assays, as was discussed, although one can infer something about the relative virus load by knowing how many PCR cycles were needed for the sample to become positive. And although a number of studies are now showing that certain individuals, particularly those with more severe disease, may manifest viremia with SARS-CoV-2, there's really no clinical role at present for testing for virus in the plasma. Much more controversial is the use of SARS-CoV-2 PCR testing for demonstrating clearance of COVID-19. In the United States, the Centers for Disease Control and Prevention provide guidance on two different paths for return to work for healthcare providers who have become ill with COVID-19. One path is symptom-based and the other is test-based. For the symptom-based strategy, workers are excluded from returning to work until at least 3 days have passed since they have recovered from any symptoms, including fever, and that means being afebrile without having to use antipyretics such as acetaminophen, and improvement in their respiratory symptoms. And at least 10 days have to have passed since the original onset of their symptoms. However, there's a parallel pathway which requires demonstration that the individual has resolved their COVID-19 by demonstrating clearance of SARS-CoV-2 by nasopharyngeal swab testing. This is the test-based strategy that first requires, of course, resolution of fever and respiratory symptoms, but also then requires negative results using an approved COVID-19 molecular test for detecting a viral RNA. This existence of these parallel pathways leads to a certain amount of confusion. So for example, at our own hospital, people who have become ill and are outpatient can be considered free of COVID-19 if they meet the symptom-based strategy. However, for inpatients, we still require demonstration of clearance of COVID-19 by a molecular test before we can remove them from strict respiratory precautions. We know, however, from a series of very well done epidemiologic studies that in fact the transmissibility of COVID-19 drops dramatically after the first several days of illness. This left panel here shows the model by He et al., published about a month ago in Nature Medicine, demonstrating that the greatest period of infectivity and transmissibility is in the 2 to 3 days prior to the onset of symptoms. And by a week after symptom onset, there's essentially no risk of transmission. Now, this model is validated by these observational data from Chung et al., published recently in JAMA Internal Medicine. They followed nearly 3,000 close contacts of COVID-19 cases and demonstrated both for all contacts overall, as well as for close contacts in the household or family, that the transmissibility in terms of the attack rate was greatest in the first several days prior to symptom onset and in the immediate days following the onset of symptoms, but essentially dropped to zero by 1 week after symptom onset. And this is regardless of whether people remain COVID-2 positive by nasopharyngeal swab testing. So we really don't understand the mechanism of that persistent positivity, but it does raise the question of the value of continuing to test people and to use clearance of COVID-2 as a clearance of SARS-CoV-2 or COVID-19 as a benchmark for either a return to work, release from respiratory precautions, or release from quarantine. Now, many hospitals here in the United States are now screening all patients on admission to the hospital in order to be able to triage those patients who need to be placed into isolation and strict respiratory precautions, and those who can be handled with what are now standard respiratory precautions, that is just use of a surgical mask on the part of the healthcare team. Similarly, women coming into the labor and delivery ward are being screened, although in our setting, we are now finding an extremely low rate of positivity among such women, not zero yet, but very low. And there's a great deal of interest in pre-admission screening or pre-procedure screening of patients who are requiring aerosol generating procedures. This may include all surgeries because of the concern for aerosolization during intubation for anesthesia, individuals undergoing upper endoscopy, as well as transesophageal echocardiography, which is very much like an upper endoscopy in some respects, and people undergoing otolaryngology or ear, nose, and throat procedures, where obviously you're working in the oropharynx or the nasopharynx. Left out of this is actually dental care, which is somewhat of a surprise. And I think that relates to the fact that most dental practices are not closely linked to diagnostic labs, but clearly providing dental care is very likely to be an aerosol generating procedure. Yet there haven't been clear guidelines suggesting that individuals coming in for dental hygiene visits or to have restorative work on their teeth performed should first be cleared by having a negative SARS-CoV-2 test. What about screening in other settings? There's been a lot of discussion, but certainly no consensus about whether employees coming back to a workplace, such as an office or the school setting, for example, should be screened prior to being allowed to return to work. There's even been a considerable discussion about the use of testing in order to allow contact sports like American football or soccer or basketball, where there's really very close contact between team members before people can be allowed to resume practice or resume play, and then potentially having them live essentially quarantined in a bubble among the team members so as not to risk introduction of SARS-CoV-2 into the group until after the games or the season is ended. Not certain how practical that's going to be. Similarly, many schools, colleges, and universities are discussing whether or not to have students tested on return to campus in the fall. And quite a few chronic care facilities, nursing homes, skilled nursing facilities, rehab facilities are requiring, in some circumstances, demonstration that the patient is free of COVID-19 before accepting them into transfer. The use of testing in all of these situations begs the question, if you are testing, then how frequently will you test? Just because an individual is declared COVID-19 free and able to return to work doesn't mean that they will necessarily remain free of COVID-19 in the subsequent weeks and months. Well, what about public health applications of virologic tests? Here, I think the principal use and the greatest importance is going to be in contact tracing. That allows the identification of asymptomatic contacts of cases who may be shedding virus, but are unaware of their infection status. And this is really going to be essential as we relax the social distancing guidelines and return to work and return to a more normal society, in order to be able to rapidly quarantine individuals who have been exposed and who may now be carrying virus, and prevent the occurrence of multiple resurgent outbreaks in the coming months. Again, whether to use these tests to allow someone to be released from quarantine has the same concerns as using testing to declare somebody free of COVID-19 after illness, because of the prolonged carriage of virus in some circumstances without evidence of prolonged infectivity. But in order for contact tracing to be able to use testing effectively, it's really going to be essential to have rapid point of care tests with a very rapid turnaround time in order to make this approach practical and scalable on a large population basis. Well, let's talk now about the clinical application of serologic tests for COVID-19. And there are three circumstances where these might be used, not all of them necessarily appropriate. One is for primary diagnosis, the second for retrospective diagnosis, and the third is the question of allowing people to return to work. Serologic diagnosis of COVID-19 harks back to a previous era of viral diagnostics before we had molecular tools, where diagnosing a viral infection typically required the access to paired sera, acute and convalescent serum, showing a rise in antibody titer. And there are occasional patients who may have a clinical syndrome that is strongly suggestive of COVID-19, but are negative for by PCR testing for SARS-CoV-2, especially if the only samples available are nasopharyngeal swabs. And in that setting, an IgM or an IgG might be useful if obtained at least 7 days from the onset of symptoms in order to make a diagnosis. In some platforms, an IgA may be more sensitive than an IgM, and so it depends very much on exactly which tests are being used. But the reliability of the diagnosis in this circumstance is entirely dependent on the performance characteristics of the serologic tests being employed. And it seems like we're learning every day, as Sanjat reviewed, about the differences in specificity and sensitivity of a number of these assays and different assay platforms. Well, what about retrospective diagnosis? Early in the pandemic, and still today in many settings, persons with mild to moderate symptoms not requiring urgent medical care may not have had molecular testing performed because they were urged to stay away from a clinic unless they really were ill enough to require hospital admission. Many such persons who are now recovered are interested in knowing if they have actually had COVID-19, and a SARS-CoV-2 IgG may be helpful in making that diagnosis. The problem here is that in some jurisdictions, once somebody has a positive IgG, there may be a requirement by the public health authorities to then obtain a nasopharyngeal or oral pharyngeal swab for PCR testing in order to exclude active disease. And that's because with certain platforms that are quite sensitive, IgG may be detected even during the acute phase of illness at a time when the patient may still be infective to others. In addition, many healthcare workers want to know if they've been exposed or have immunity to the virus. Most experience to date suggests that, in fact, a very small fraction of such individuals will actually be positive, and the seropositivity rate depends on the availability and proper use of personal protective equipment. The more available and the more consistently such PPE is used, the better protected the healthcare workers will have been, and the lower the likelihood that they have become infected and would have any antibody. Well, what about back to work? This is perhaps the most controversial area. And I would say that results of serologic testing should not be used as a criterion for determining who can come back to work. This is because the majority of the population around the world is still likely to be seronegative, and I'll show you some data in a moment. Also, there's no guarantee of protection just because you are seropositive or how long such protection might last. And one cannot emphasize enough that regardless of serostatus, being seropositive is still no substitute for the use of appropriate personal protective equipment, be it a simple surgical mask in normal social and work situations, or more confining PPE in certain healthcare settings. Well, this folds into the discussion of public health uses of serologic tests for COVID-19. And here, the most important use is to perform well-done population-based serosurveys, random sampling of large populations, which are essential for refining our understanding of COVID-19 epidemiology. Of course, that raises the question then of what do you do about those individuals who test positive for IgG, some of whom may have acute infection because of the ability to detect IgG very early on with certain platforms, as I discussed in a few slides ago. But this testing really has no role in determining when to relax social distancing, despite considerable media interest and interest on the part of many government authorities on potentially using antibody testing to tell us when we can go back to work as a society. If current measures have been even moderately successful, the majority of the population is going to be seronegative. And as I've said, seropositivity is no guarantee of protection against reinfection, at least not known to be protective, and the duration of such immunity, if it exists, is uncertain. Just this week, there was a very interesting analysis published in the New York Times using data from several surveys reported independently from a number of cities. And what you can see in the upper left panel here is this is what the situation would be if roughly 2/3 of the population was seropositive. The prevalence of antibody positivity needed to have herd immunity. And shown in the remaining circles is the actual seropositivity rate in various major cities around the world, including New York, London, Madrid, Wuhan, and Boston, where the rates range from nearly 20% in New York to about 10% in Boston, well below the 60% threshold needed to approach herd immunity. So we really shouldn't expect there to be sufficient immunity in the population to allow for return to work. We'll need to return to work with appropriate social distancing, wearing masks, and taking effective measures to prevent the ongoing transmission of SARS-CoV-2. So in conclusion, rapid progress has been made in developing virologic and serologic tests for SARS-CoV-2. These tests have a wide range of sensitivity and specificity depending on the particular platform. Both types of assays have important clinical and public health applications, but assay limitations must be kept in mind when interpreting individual patient results and establishing public policy. And let me end just by acknowledging a number of my colleagues who either provided some data to help my talk or with whom discussions have really helped shape my views on this important topic. And I'll turn this back to our moderator.